and Tadvidya Sambhashanam. So Tadvidya Sambhashanam is a high need of this era also. So we are happy that the current speaker is from Kerala. So I congratulate all the Vishwa Ayurveda Parishad Sambhashana Shibiram organizers for conducting and inviting Dr. Subin Vaidya Madam sir from Kerala. Kerala is a high known place of, and is also known as the cradle of Ayurveda, where 101% pure Ayurveda is being practiced and better results are also being got. Throughout our country, more Ayurveda pure practitioners are increasing day by day. So, we hope that Dr. Subin Vaidya Madam sir will enlighten us with the role of Panchkarma in neurological disorders, and will encourage and will boost us our morale to learn and practice Ayurveda in the coming days. Okay, I once again congratulate and I bless all of our Karyakartas for a successful webinar. Thank you.
Thank you, Dr. Vaidya Adarsh Ravi. I request Rashin Chandrasekharan to introduce our esteemed speaker, Vaidya Subin Vaidyamadhan.
It's my privilege to introduce today's guest speaker, Dr. Subin Vaidyamadam, for Panchkarma Sambhashana program. He was born in famous Vaidyamadam family, and he is trained under late Ashtavaidyan Vaidyamadam Chiryanarayanan Nambudiri and Dr. V.M. Rishikumaran Nambudiri. He is graduated from Sri Jayendra Saraswati Ayurveda Medical College, Chennai. He has completed MD in Panchkarma from DGM Ayurveda Medical College, Gadag, Karnataka. Now he is PhD scholar in Kerala University Health and Science, Thrissur, Kerala. And he had presented and published in various conferences and various journals. And he is worked as Panchkarma Medical Officer under Indian System of Medicine nearly 5 years. He is the first Ashtavaidyan to join academic service under Kerala Government Services. Currently, he is working as Professor, Department of Panchkarma, Vaidyaratnam P.S. Vaidya Ayurveda College, Kottakkal, Kerala. He has awarded Best Orator in Sanskrit in Madras Sanskrit College in 1997, and he got Best Poster Presentation in International Ayurveda Summit, Bangalore in 2003. He was also coordinator of National Eye Mission Project on Non-Communicable Disease Project in Nirama. He has associated with multiple research and academic projects, and he was received state, national, and international level seminars, workshops, and conferences. Doctor, we are really honored to have you here as chief speaker for this program. We have audience from all over the India, and I welcome you, sir. Thank you.
Namaste, namaste. Thank you, sir. Thank you for the nice words. Namaste to all. Shall I share my presentation? And
yes, you may share, sir.
Okay. A moment, please. So, is my screen visible to you? Am I audible?
Yes, sir. Yes, sir.
Yes, sir.
Okay, let me begin with a small prayer. Gurave sarvalokanam, bhishaje bhavaroginam, nidhaye sarva vidyanam, dakshinamurtaye nama. I bow my head before Lord Dakshinamurti, the Lord of all knowledge. I also bow my head before my ancestors, because of whom I was exposed. I got the opportunity to learn Ayurveda and provide service to the society in this sector. First of all, I thank all the office bearers, Karyakartas of Vishwa Ayurveda Parishad, especially the organizing secretary, convener, co-convener, everyone, each and everyone behind this wonderful setting for inviting me to this talk. So the slide shows a few of my ancestors, my great-grandfather, grandfather, his brother, my uncle, all who were Ashtavaidyas belonging to the traditional practitioners of Ayurveda in Kerala. So the today's topic allotted to me is role of Panchkarma in neurological disorders. So at the outset itself, I want to be clear that within the time frame allotted for today's program, nearly 1.5 hours or so, it is impossible to look into each and every neurological condition and its management. So I have set some priorities depending upon the general practice or the challenges that the general practitioners face in the sector of neurology, and selected a few conditions and looked into the detailed understanding of their management perspective. So the focus areas that will be covered today is a better understanding of the pathology of major neurological disorders, and depending upon that, the approach considerations and the management options and the outcomes that we need to focus. Then defining the limitations or boundaries while treating these conditions, and mixed with them the Panchakarma experiences that currently we practice here routinely. So these will be the focus areas of today's presentations. So let us begin with a general refresh from our Vata Vyadhi treatment principle. So every one of us will be familiar with the beginning verses of Vata Vyadhi Chikitsa, either from Charaka or Vagbhada. So it is the Kevala Vata treatment, that is the Nirupastambha Vata treatment that is explained in the beginning, which goes on with the Sneha Sweda Chikitsa. That is a textbook scenario which is mostly not encountered frequently in our clinics. Most of the conditions, except in some Jangala Deshas, in some particular communities, most of the Vata Vyadhis that we get have some association, isn't it? Some samsarga or some margavarodha may be there, which points us to the other possibilities of Vata Vyadhi Samprapti. That is, the apart from the Dhatu Kshaya, the Margavarana Samprapti also needs to be remembered. So the Margavarodha can happen due to Anya Dosha in any of the Srotasas, can also be due to some Dhatus also. The Avarana of the Vata, that is possible not only by doshas, it can also be between themselves, that is the Anyonya Avarana. So whenever we start with the management or treatment of any of the Vata Vyadhis, especially the neurological disorders, we have to look into the possibilities of the presentation, the clinical presentation belonging to any of these categories. That is either the Kevala or the Samsrishta or the Avarana Janya. Without looking into this, without being open into the possibilities of the disease condition being associated or falling into any of these categories, it is impossible to frame a Samprapti Vikhatana, which is the essence of our treatment protocol. So, whenever we encounter a case, whether it be a Pakshakhata or an Ardhita or a neurodegenerative disease or a dystonia or a Mastisha Kshayajanya Vyadhi, whatever it is, we should form a hypothetical Samprapti. That should be very clear. Of course, individual Samprapti of each Roga is explained in the text. That is fine. But the possibility of the Vata Vyadhi originating either due to a Santarpana or an Apatarpana should always be considered. Let us see how it is framed. So when a combination of etiological factors like Ahita Bhojana, which comprises of Ruksha, Kshara, Amla, Lavana Bhojana, or Akala Bhojana practices like Vishamashana, okay, and or the Viharas like Adivyayama or Bhaya, exposure to Bhaya, Krodha, Shoka, causes Vishamagni and also Sroto Daurbalya, particular to Majjavaha Srotas, and there is a Dushti of the Asti Dhatu Agni. Then there is always a possibility of Apatarpana Janya Rogas. So most of the Dhatukshaya Janya Vata Roga has this Apatarpana Janya, 99% has this Apatarpana Janya Samprapti in the background, happening in the background. So we will always have to remember that this kind of dosha dushti, the etiological factors behind them contributing to a particular etiological process will make a definite influence over the manifestation, and hence our Samprapti Vikhatana should be planned accordingly. So what will happen further is, in this kind of Samprapti, when there is a Kevala Vata Kopa and there is the Dushti of Majja Dhatu in the Majjas Srotas, things are not happening in the proper way, causing a disturbance in the metabolism and promoting the Kitta Majja Vriddhi. When factors like Jara, old age, or continued Astidhatagni Dushti and Majjakshaya due to continuation of etiological factors, the Vada Pragopakara Nidana happens, then there is the Dhatukshaya Janya Samprapti manifesting as the Vaikrita Karma of Pranadi Panchavada. Also, the similar Apatarpana Janya Samprapti should be expected when there is an Anyonya Avarana of Vata dosha. That means the prana doing avarana of Udana or Udana doing avarana of Vyana, the Panchavada getting avarana between themselves. In that kind of avarana also, it is the Apatarpana Janya Samprapti that is running in the background. on the contrary, when we are considering the Santarpana Janya Samprapti, there is the Ahita Bhojana, but the factors contributing to Ahita Bhojana are here Snigdha, Guru, Abhishyandi Ahara. And also the Akala Bhojana, the practices here are Adhyashana or Ajirnashana. And the Ahita Vihara, like Divaswapna or Avyayama, sedentary lifestyles. When there is a combination or continued pursuance of these etiological factors, there can be a production of ama, which is kapha pradhana, and the atidushti-janya ama. So if you remember the verses from the ama chapter, tebhyo eva adidushtebhyo. So when there is an adidushti of doshas, ama can be produced. Here the factors are contributing to the santarpana, so the adidushti is of kapha. So that will cause upalepa in the srotas, which will in turn cause the concerned dhatu agni dushti. And there begins the santarpana janya santapa. So when there is a santarpana janya roga, like in obesity, that causes the gati nirodha of vata. And when the prakopagara nidana and the dhatwagni dushti and the kabha dushti is continued, that will manifest as a obstructive gati nirodha janya manifestation in the Madhyama Roga Marga. So this most commonly happens when there is Anya Dosha Avarana, and there the Vaikrita manifestation is according to the Vaikrita karma of the Pranadi Panchavada. So when we see this separately, the Shastra Bhaga is like that. We can visualize it in this way. When there is a Anya Dosha Avarana, that is in case of the Santarpana Janya Samprapti, there is the sustained Avyagata Gati of Vata, which is obstructed by some other dosha. Then what will happen? Tebhyo Anya Dosha Purnebhyaha Prapyava Avaranam Bali. There happens the Vimarga Gamana and Sangha in the Srotas, which causes the manifestation as neurological disabilities or generalized features, which is explained by Charaga beautifully as Karoti Avrada Margatvat Rasadimscha Upashoshayet. Whereas in case of Anyonya Avarana, it is the Vata Kopa that is dominating. So there is Vimarga Gadi. But what happens is that Chakravarti explains it very specifically that when the Vata is vitiated beyond magnitude, Ataha Kupitaha, Pitta Kabhau Samudirya, it takes along with it the Pitta and Kabha. Tabhyam avrada margobi tatra tatra padeshe gadan karodi. So when there is the vimarga gadi of vata, that can involve, that can initiate pitta and also kabha also in its samprapti. But here it is mostly anyonya varna. That is why they say that pranadayaha tadha anyonyam avrunnandi yathakramam. And the neurological disabilities and generalized features can manifest here. So when we are considering the dhatu kshaya, which is most commonly found in many of the neurological disorders, there we have to remember that that may not be preceding the dosha kopa. Okay, in some cases after dhatu kshaya, there can be manifestation which is kevala vata roga, but in some conditions Vaikrita or Kupita Vata can lead into Dhadukshaya also. The Shastra Bhaga corresponding is like Doshaha Pragupito Dhadun Kshabayati Atma Tejasa. So how that happens? The dosha can cause Dhadukshaya when it is Kupita. So Vayu can do that by its Shoshana character property. Pitta can do it by its Ushna and Katu nature. Kapha can do it by Marga Avarodha. So the Sushruta very clearly explains this, that Kapha Pradhana Doshairhi Ruddheshu Rasavartmasu Kshiyante Dhatavaha Sarve Tata Shushyadi Manavaha. So when even the Dhatu Kshaya can be produced as an after effect of Dosha Kopa, this we have to remember. So always it's not that Dhatu Kshaya means only Kevalavada. Directly we can start with some Abhyanga or Snehana or Brahmana Karma. This is the common fallacy that practitioners tend to commit when there is a Vata presentation and associated with some Dhadukshaya. We tend to misinterpret or take it for granted that all these are due to Dhadukshaya, so we should immediately do Snehana or Brahmana kind of treatment. This should be checked. We should be very cautious, and we should try to frame the Samprapti whether it is falling under the Apatarpanajanya Samprapti or Sandarpanajanya Samprapti, and then only try to approach the or plan the treatment. So when we are looking into the manifestation, that is the avarana of pranadi panchavada in the srotas, or especially the roga marga, mostly madhyama roga marga, their prakrita karmas, that is the praspandana, udvahana, urana, viveka, dharana is affected. So there is some sort of disarray in any of these prakrita karma of the panchavada. So this is a common refresher at the beginning that I want to discuss with you, because most of us start jumping into or mapping into some particular treatment or some particular medicine and the disease without considering the possible samprapti. So always you should remember that we should begin with framing a samprapti at first, then only link them to any kind of treatment procedures or medicines. Now, one other focus area of or a separate area that we have to discuss is the management of neurodegenerative diseases, because there are some factors or some aspects which are exclusive to them, a little bit different from the neurological ailments, common neurological ailments. So when we see the neurodegenerative diseases, the group are traditionally defined as disorders with selective loss of neurons and distinct involvement of functional systems defining the clinical presentation. So most of the neurodegenerative disorders, their clinical presentation is defined according to the involvement, particular involvement of the functional system, which are related to the loss of neurons. So some important conditions that we encounter in today's practice are motor neuron disease, Parkinson's disease, ED related disorders. Sorry, hello. Is there any problem?
No, sir, please continue.
Okay, okay. I heard some voice in between, that is why I stopped. It's still there. I think some of the participants mic is on. Okay, fine. Motor neuron disease, Parkinson's disease, PD-related disorders, Alzheimer's disease, so and so, some of the important conditions. So when we see the neurodegeneration basics, we know that there is a progressive loss of structure and function of the neurons. So here there are visible changes apart from that of the atrophy, indicative of the damage to the cells. How it is happening, there can be some pathology defined with the degeneration. That is, in the clinical setting, when we define degeneration, it is a deterioration of the structure or function in absence of inflammation, neoplasia, infection, or ischemia. Okay, so there is a kind of a deterioration of either the structure or function that is very clear. So a combination of factors are working behind this etiopathogenesis of neurodegenerative disorders. Right from the top, the genetic factors or the age-related factors, environmental factors, all these things which are non-modifiable factors, okay, and leading to the dysfunction, especially the dysfunction of the mitochondria, the altered protein modification or protein misfolding, protein aggregation, all these can occur. Along with that, sometimes there is oxidative stress or direct exposure to metals also, that is toxicity, that also causing to the neuronal death. So the degenerative changes that we can see in the nervous tissue are the cloudy swelling or the degeneration, or the hydropic or vacuolar degeneration, fatty changes, hyaline degeneration, mucoid and myxomatous degeneration, generalized atherosclerosis, and amyloid degeneration. So these kind of changes will be seen in the nervous tissue. And in case of MND, that is the motor neuron disease, which is a big headache for a general practitioner, the manifestation can happen in many sorts. It can either present as an ALS, which is a commonly most common form, and in which there is muscle wasting, weakness, fasciculation, which is very important factor for its diagnosis, speech and swallowing problems, and muscle spasm. PMA, that is the progressive muscular atrophy, is a less common form, and the progress is very slow than the acute amyotrophic lateral sclerosis, that is the ALS. Here there are no muscle spasm experiences, and also some of the PMA cases may later develop ALS also. Progressive bulbar palsy, this form of MND is very difficult to treat. Okay, the characteristic feature defining a progressive bulbar palsy is the feature called emotional lability. That means it affects the expression of emotions, and people might laugh or cry for no apparent reason. Other features like the ALS will be present. Then there is a rare form called the PLS, that is the primary lateral sclerosis, which is a rare form in which people experience spasticity, but no muscle wasting or fasciculation. Whereas in Parkinson's disease, there are the primary motor signs like the tremor of the hands, arms, legs, jaw, and face, bradykinesia or the slowness of the movement, then the rigidity or stiffness of limbs and trunk, postural instability or impaired balance and coordination. Along with that, we will find presence of Lewy bodies in the midbrain when we are going for any imagiology, and also brain stem and olfactory bulb also. Some non-motor functions also may get involved, like the sense of smell, sleep regulation, and even the intestine, that is the constipation-like features. That's a common thing that we have found over the past 5 or 10 years in our hospital. Many of the PD cases present or associate with constipation. So because of the dopamine cell in the intestine, some gastrointestinal symptoms may also get associated with Parkinson's disease. Then, other than PD, we have certain Parkinsonism. So, all is not Parkinson's disease. There are other Parkinsonism also, like MSA. MSA is a very difficult condition to treat. It's also commonly known as Scheidegger syndrome. So, in that case, there is stiffness and slowness of the movements. But there are other features like incontinence, difficulty with swallowing, and dizziness, which differentiate it with PD. Then there is the progressive supranuclear palsy. This is also a rare condition, but we have had cases with them approaching us. So in that, there is eye movement, involvement of eye movement, balance, mobility, speech, and swallowing. Then there is a condition called normal pressure hydrocephalus, which also affect the lower half of the body very commonly. There are walking difficulties, urinary incontinence, memory problems. Commonly, it is relieved by removal of CSF. There is also a condition called vascular or atherosclerotic Parkinsonism. Usually in geriatric age group, this will get commonly, who have metabolic or endocrine disorders like diabetes. There is altered microcirculation affecting the functions of the brain, which might cause development of this condition. So people with stroke, people with a history of stroke, they have the risk of developing vascular or atherosclerotic Parkinsonism. Then there is drug-induced Parkinsonism. Some drugs can also cause a Parkinsonism, which is usually reversible if you withdraw the drug. Atypical Parkinsonism or Parkinson's plus is a diagnosis that we commonly find nowadays when there is a lack of clear-cut consensus in differentiating any of these conditions. So we have plenty of neurodegenerative disorders coming into our practice, or ourselves getting exposed to these conditions rather than the normal common neurological disorders. That is why I have included these things in today's discussion. Alzheimer's disease is commonly affecting the memory, even the cognitive impairment. Apart from that, there can be non-memory aspects of cognition also, like word finding, vision, spatial issues, impaired reasoning or judgment. These features can also occur in that. Personality and behavior changes can also be a feature of this Alzheimer's disease. So whenever we get a neurodegeneration, because there is a tag of degeneration in that pathology, do not jump into a conclusion that this is happening due to dhatukshaya or apatarpana. Again, we should consider the possibility of dosha kopa causing the dhatukshaya. That is like in the case of anyonya avarana. So all neurodegeneration may not be apatarpana. This is a reminder that I want to repeat. Okay, so do not start the treatment with Kevalavata treatment measures. Do not jump by doing some Snehana, Swedana, Brahmana kind of treatment in neurodegenerative diseases. We have to be very cautious. We have to frame the Samprapti according to the Samprapti only. We have to plan the treatment. So see, if we are trying to correlate some of the features of MND, we can easily find that in ALS, to take an example of ALS, in ALS, we can easily find a Kabha Avarana of the Prana, Udana, and Vyana. You can see the marked text in the slide. In Shleshma Avrata Vata or Prana, there is Sada, Udgara, Nishwasa, Uchwasa, Sangraha. All these things are very commonly found in ALS. Guru Gatratvam, Aruchir Vak Swaragraha, Balavarna Pranasha. In Dhyana, so that is regarding the Udana. Then regarding the Vyana, Parvasti Vagraha, Skaridam cha Gadau Bhrisham. So these features we should be commonly open to all these features, whether the presence of these features tend to suggest that there is an avarana in pathology in these conditions. Now, see the Parkinson's disease again. There also Kabhavrata Vyana. When we see the Kabhavrata Vyana, there also Kadgadi Sangha is there. Guruni Sarvagatrani, Stambhanam cha Asthi Parvana. All these things can be found in Parkinson's disease. Of course, Kampavada Lakshana is separately described in Basavarajiya and all, which is given here. Karabada Tale Kambo, Deha Brahmana Dukhide, Nidra Bhango, Madikshena, Kampavadasya Lakshana. But this Kampavada may not be always due to Kevala Vata or Dhatu Kshaya. It can also be. So the same disease can fall into any of these categories. So depending upon that, our treatment approach should vary. That is the message I want to discuss with you in today's talk. And also see the Alzheimer's disease, apart from the Dhatu Kshaya and Anyonya Vata Avarana features. We can also find some features of Oja Kshaya in Alzheimer's disease. So a treatment approach targeting that would naturally benefit the patient. So we should be open to these kind of considerations while treating any of these conditions. So moving on to the next part, that is the considerations regarding the management and outcome. We have to stick on to a guideline regarding the selection of management protocol, which should emphasize or prioritize on the Atura Avastha also. That means what is the condition of the patient's perspective based on the activities of daily living, age, mental status, comorbidities. All these should be a deciding factor in selection of the management protocol. Moving on. The Roga Avastha, depending upon the Samprapti Khadagas that we have already discussed, and the dominating dosha, and the chronicity or acuteness of the disease should also be the deciding factors in selecting the management protocol. And also we should remember that when we are doing a Shamana or Shodhana Chikitsa, it is the effect that we are looking into, isn't it? The curative effect or the eliminative effect is what we are looking into while we are doing the Shamana and Shodhana. But when we are focusing on Brahmana and Lankhana, like if the case is of Apatarpana Janya Samprapti, we are going with the line of Brahmana. That Brahmana is an outcome that we expect that comes after the effect. So in the gradual course, some treatments, like see for an example, we do several kind of Swedanas, we do several kind of Bahya Upakramas. Some of them depending upon their placement in the treatment protocol can produce Brahmana effect and Lankhana effect also. So that we can visualize only by observing the outcome. So we should always be thinking about that. So for example, a common peripheral neuropathy that we have, a peripheral neuropathy or an entrapment neuropathy. Some of the cases respond well with Brahmana Chikitsa, some of the cases respond well with Langhana Chikitsa. We have had cases which respond well with local Tailadhara or application of some Avarti Snehas like Dhanvantaram Avarti. At the same time, we have some other group of patients who have benefited with doing Kashaya Dhara or Dhanyamla Dhara. That means the patient sitting in front of you is either Brahmanarha or Lankhanarha. Our duty is to find out whether he is Brahmanarha or Lankhanarha. There cannot be any other kind of treatment possible in Ayurveda. Our duty is to fix him in any of these categories. This thing we should remember while considering any management protocol. So let us see some of the approaches that we commonly employ. You take the stroke, Pakshaghata Chikitsa. We have to have a clear-cut differentiation basing on the pathology and clinical presentation. That means whether it is due to ischemia, whether it is due to any hemorrhage, whether it is due to any space occupying lesions, which area is involved, whether there are multiple infarcts, depending upon the clinical presentation and the samprapti, whether these the presentation can be categorized into Kevala, Samsrishta or Avritavada. So this approach will definitely lead us into employment of some Rukshana measures if it is Samsrishta or Avritavada. If it is Kevalavada, of course, no need to tell, we can initiate the Snehana protocol. So in case of Rukshana protocol, we have found good results in the initial stages of removing the Avarana or removing the Samsrishta dosha by Udvartana, Dhanyamla Dhara, Ruksha Churna Bindasveda. These are the measures that we commonly employ for Rukshana in Samsrishta or Avritavada. So when we are considering the Swedas in general, we have to visualize them in a scale of Ruksha and Snigdhata. Okay, that is why I am putting this in this slide. We have a list of Sweda procedures which we can place into some particular spot in the Ruksha Snigdha scale. So on the extreme end of the Ruksha scale, we have the Valuka Sweda. On the extreme end of the Snigdha side, we have the Mamsa Pinda Sweda. So depending upon the need, whether it is Rukshana or Brahmana or Snehana, we have to select any of these Swedas accordingly. Now, in case of Snigdha Sweda, we have good results with Churna Penda Sweda of Kolakulathadi and also Punnagadi. Punnagadi formulation. Punnagadi is a formulation which is well studied. In our institute, we have had a study in stroke with compare both Punnagadi and Kolakulathadi, which gave good results. Kayaseka, which is also commonly called as spiritual in Kerala, is a good option in case of Snigdha Sweda. Snigdha Virejana is to be adopted if there is a, if you remember the Vadavyadhi Chikitsa, when you are not finding pacification with adoption of Sneha Sweda measures, you have to infer that there is some associated dosha, which can only be cured by Virechana. Yadyanena sadoshatvat karmana na prashamyadi mrudubhihi sneha samyuktaihi shodhanaistam vishodhayet. This is the justification or placement for adoption of Snigdha Virechana. And of course, no doubt, Vasti Karma should be done in all feasible, all fit patients of Pakshaghata, whether it is Yogavasti or Kalavasti, with Ardhamatrika, Madhutailika, or the Belaguluchyadi or Kshiravasti combinations, whichever are popular in respective practices, should be applied as Yogavasti or Kalavasti. Now, when we are treating stroke cases and in general the neurological cases, selection of thyla is a challenge to the physician. So what we do here is that when there is a cerebrovascular disorder, CVD or CVA, then generally Makarpa Sasthyadi, Marha, Masha like thylas are prescribed. When it is a spastic kind of presentation, we tend to use Kotam Chukadi Thaila, Pichinjadi Thaila, like Snehas. When there is a neuropathy, as in case of some polyneuropathies like in Guillain-Barré syndrome and all. Even the rakta should also be taken into consideration. That is Pinda Taila from the Vadarakta Prakarana. Kshirabala Taila should be adopted. When there are lesions which are extrapyramidal in nature, apart from the Mahamasha Taila, that's commonly in PD and all, we use the Mahamasha Taila and Karpa Sasthyadi Taila. We can use Thailas like Vadashani Thaila, which is explained beautifully in text, Kerala text like Arogya Raksha Kalpadruma. Arogya Raksha Kalpadruma explains the Vadashani Thaila. And we have to also, after following the Vasti, we have to also adopt the Nasya Karma, analyze carefully and ascertain the type of Nasya to be done, because both Virejana Nasya and Brahmana Nasya are beneficial in stroke cases. But depending upon the case, we will have to decide, okay, which kind of Nasya is to be done in that particular stroke patient. So when we are going for Virejana Nasya, usually we go with Karpa Sasthyadi Thaila, which has some Shodhana effect also. When we are going for Brahmana or Snehana kind of Nasya, we prefer Shuddhabala Thaila for the Nasya purpose. Some situations, like in a case of hemorrhagic stroke, if it is acute, better avoid doing Nasya in the initial phase. And also when there is a space occupying lesion found in the imagiology, similar approach should be done. And if we are having a marma background, we can also go, that means some pitta rakta features are there, we can go for the Kshirabala Avarti. Marma involvement is there, we can go for the Dhanandaram Avarti. Then in human lesions, when the stroke has more of the upper motor neuron characteristics, you have to plan for repeated course of Nasya Karma. And when there is aphasia associated stroke, then we have to select some Medhya Dravya for the Nasya Karma, like Jyotishmati Taila, which is very common in northern parts of our country. Jyotishmati Taila practice. Even now we have popularized that in Kerala also. So along with that, we can go for the Murdha Taila procedures like Shirovasti, Shirodhara, etc. Moving on. See a version, what do you say, case report on a particular presentation of a Guillain-Barré syndrome, which we had treated a few years back successfully, is shown here. So that Guillain-Barré syndrome, it has several variants. It can present as Aman, Asman, or ADP. Many possibilities are there. This case was a case of Aman. Aman was treated successfully, even though its prognosis is better compared to other variants of GBS. there was no improvement for the patient in undergoing the modern management. So he came to us and it was treated successfully with Ayurveda procedures. Moving on to another condition, Ardhita. We have to always remember when we are treating a case of presenting with facial paralysis, then if there is a history or a background of infection, that should be identified. That should be clear at the outset itself. And after that, your approach can be very similar to Pakshaghata, but when we are going for Nasya Karma, we should try to do the multiple installations of Nasya Karma with Sweda Karma in between, particularly because the sthana, Udbhava sthana and the Vyakti sthana of the disease is the same. Okay, so the focus is on Nasya Karma majorly. So that Nasya Karma has to be done to a maximum beneficial outcome. And also Talams. Talam is a peculiar treatment that we advise as part of the Keraliya Kriya Krama. When it's a modification or a combination of Piju and Leba or Abhyanga and Leba. So there is the Navanita Leba known as Vennattalam or the Erenda Talam, that is the common Avanakenna Talam, which we combine with the Nasya therapy, and also we commonly prescribe Kshira Dhuma in the cases of Ardhita. So another case which can be correlated with the presentation of Ardhita, there was a case of traumatic chronic facial neuropathy which we had treated here in our hospital. So that 10% of the patients of all causes are reported to have no recovery from the condition. But the case that we got here was a resultant of tooth extraction with a history of 8 years. We had given her that patient particular Panchkarmas and got good clinical improvement. Moving on to some Avaranavada conditions like or Mastisha Kshaya conditions like Parkinsonism. When we are going for treatments like Nasya and all, we have to aim for Shodhana Nasya. So in that Shodhana Nasya, other than Taila, we have to go for Swarasas also. Can use the Swarasas also, like the Shankhapushpi Swarasa or the Shankhapushpi Kalka mixed in Shira, and then follow it up with Sneha Nasya like Rasna Dashamula Krita or the Tailas, commonly which we are doing as the Sneha Nasyas. Benefit is got with the courses of Dhanyamla Dhara in initial phases, especially when there is Avarana, as we had seen in the case of stroke. So we go for either a Dhanyamla Dhara or the Rukshana measures like Ruksha Churna Pinda Sweda or Udvartana if there is a Avarana pathology, especially of the Kabha origin. Otherwise, if there is the Kevalavadi Mastishka Kshayajanya Samprapti, then we go for procedures like Shirodhara, Shirovasti, etc. In case of ataxia, we have got some good results with Nasya. Ataxia conditions, when patient presents with most commonly sensory ataxia features, even the motor cases also, we have got some improvement with the Thailanasya. And as per the presentation, that is, if there are seizures or involvement of cognitive impairment or spasticity, the Nasya can be selectively advised. So if there is seizures, say there is a Vatika kind of presentation, then some Thaila Nasya can be done. If there is some spasticity, when there is such kind of Kabha features, you can go with some Churna Nasya, that is the Ruksha kind of Nasyas. dystonia is a focal dystonia. Especially I am restricting to focal dystonia here, like local limb dystonia, that is the writer's cramp that we get, or the torticollis. We get these conditions very commonly. So in those kind of dystonias, we can get good results with Nasya Karma itself. For example, in writer's cramp, if you do a course of Brahmana Nasya and follow it with Shashtiga Annalepa or Shashtiga Pindasweda, you will get good results. And is in case of Shodhana focal dystonia, that is the total torticollis. If we go for the Ruksha Nasya, that is the Rasnadi Churna, commonly done in our hospital and all. We can get, when we combine it with some other Ruksha measures like Dhanyamla Dhara or Valuka Sweda or Ruksha Churna Pindasweda, we get good results. In case of ALS, when we are going for Nasya and all, where there is always a word of caution to be exercised, because if there is a involvement of degglutination affected, and that can lead into a risk of aspiration. So when we are treating cases of motor neuron disease with Nasya Karma, be careful to advise it as Pradimarsha, not the Marsha kind of Nasya. And also, while treating conditions like multiple sclerosis, we can get favorable results. I'm not saying that we can cure the multiple sclerosis condition. We know that we have several limitations, but improvement is seen with Brahmana Nasya, with Kshirabala Tailam and Madhyashthyadi regarding the cerebellar symptoms and the trigeminal neuralgia, which is a common association with multiple sclerosis, and the eye symptoms of the MS patient. Seizure disorders, when we are going for Nasya, we can go for Prathamana Nasya and Snehana Nasya, again like the presentation. If there is a Vadiga kind of presentation, we can go for the Snehana Nasya. If there is a Kabhaja kind of presentation, we can go for the Prathamana Nasya. And we have to remember that we have to follow it up with Shamana Snehapana. It's not the Shodhananga Snehapana, it's the Shamana Snehapana with either of the Kaidalyanaka Krita or the Panchakavya Krita like medicines. So there is an important point here to remember regarding the neurodegenerative disorders, because there has been an observation from the biomedicine itself that limitations of a neurocentric approach is there. So there many of the therapies which have been tried out in managing neurodegenerative disorders lack in success because of their neurocentric approach. So when they are saying they are bringing in newer concepts like proteinopathy concept in the pathology of neurodegenerative disorders. So it is more complex. So there is an evidence of participation of non-neuronal cells also in the disease process. So it's better always go for the multiple targets. That is, single mechanism should not be targeted. Do not go for only therapies that are focusing on the neurology. You can go target all other. You treat the constipation. For example, you treat the constipation, or if you have a patient with a comorbidity of diabetes, you treat the diabetes. That will in turn benefit the patient equally or more better than the neurocentric approach. So functional and cognitive impairment should not be considered as outcomes of malnutrition alone. That is one important thing. Again, we have to remember. That means whenever there is a kshaya in the karma, that should not be considered as a apadarpanajanya samprapti. And when we are treating all these neurodegenerative diseases, we have to go for a multifactorial approach, as there are still many unknown factors or genetic factors we haven't identified yet. So some of the treatment may respond to that. And preventing and supplementing treatments of comorbidities like diabetes or alcohol consumption, hypertension, stroke history, all these things should be targeted while treating the neurodegenerative disorders. And also, we have to define the limitations and boundaries of our scope of management, because staging and specific conditions are very important, isn't it? Our Acharya himself has told, well, mentioning about the Kala, Ksanadir Vyadhyavastha cha Kalo Bheshaja Yogakrit, isn't it? So if we want to get the optimum benefit of our treatment, we have to understand the Vyadhyavastha. Understanding the stage is very much important. For example, if we take the case of MND, if the general prognosis in MND is 5 years. This is a general statement, it's not a fixed one. But if we are if we are getting a case which has chronicity more than 5 years, you should restrict yourself into offering hope to the patient. Likewise, in case of PD, which has a history of 10 years or more, there is limited scope. In case of Alzheimer's disease, more than 8 years, there is restricted scope. All these things we should identify, we should remember properly and explain it to the patient if he or she is falling into any of these categories. And one more point in case of the neurodegeneration, there is a new concept called neuroregenerative reserve. When we are treating the patients in the early stages and medium stages, okay, there is a possibility of neurogenesis, neuroplasticity, and neurorestoration. Previously, they used to talk only about neuroplasticity, but now they have coined a new term called neuroregenerative reserve and combined neurogenesis, neuroplasticity, and neurorestoration. This reserve may get activated as proper stimulation or supply of growth factors restores some of the cognitive loss and ameliorates behavioral skills. So while treating these conditions, especially falling into the early and medium stages, no matter what treatment you do, there is a likely chance that you might touch upon this part. So do not hesitate in treating these patients. Go boldly and treat if they fall into the early and medium stages. And focus on the activities of daily living and control of comorbidities. So do not focus merely on the disease outcome measures. Okay. There are realistic disease control measures only we have to focus. We cannot completely reverse the pathology in multiple sclerosis or a case of progressive bulbar palsy or a case of supranuclear palsy. We can at the same time improve the quality of life by focusing on activities of daily living, comorbidity control, etc. That is the pragmatic approach that we have to always be keen on doing. So it should be Rogi directed and not Roga directed alone. It is very common nowadays that the patients do all the search in the internet, in Google and all regarding the details of the disease and share their gyan with you, isn't it, in the clinics. It's a common experience shared by all in the general practice. So we should take some time to educate them that our approach is directed on the Rogi and not the Roga alone. So it should be focused. And we have to focus on Adura Bala also, not only on the Dosha, Dushya, and Vyadhi. Why I am telling you is that when we are treating with Udvartana, for an example, some cases of Udvartana, some cases of motor neuron disease or some debilitating conditions. Take an example, a flaccid stroke. Their Udvartana cannot be done with common Ruksha churnas like Kolakuladhadi or Yava Kolakuladha, like that. There we use the Shashtiga Tandula churna. See, Shashtiga Tandula, we are not making it as a Sweda. We are not cooking it or making it as a pottery. Instead, we are just frying it and powdering it and using it for Udvartana, which will not only help the patient to improve his bala also. So preserving that bala is also important. Take into consideration the desha and kala also. So in that management perspective, let us come to a protocol. A protocol is important. It's not as individual. I always believe in that way. It's not the individual medicines or the individual treatment that is going to benefit a particular disease. It's always the protocol. So when we are starting a protocol, we have to identify that whether the patient needs rukshana or pajana, and that identification of the optimum level of rukshana is important. For that purpose, remember, we have to work on the samprapti, whether it is santarpanajanya or abadarpanajanya, and accordingly we start with the pajana. So depending upon the necessary level, you can go for the ruksha pajana or the snigdha pajana. Give rukshana if needed, then follow it with anulomana. That is whether it is snigdha virejana or vasti karma, we can go for the respective procedure. Then follow with the rasayana or shamana. Here shamana means in all cases rasayana may not be feasible, isn't it? So some individual drugs can be administered either separately or as a combination according to the disease. So when we are going for pajana, commonly what we use here, I have just put them. If it is a ruksha pajana, we go for the chitragadi kwatha from the sushruta. The Sushruta starts with the Shadharana Yoga, Chitragendriya Patha, Kadagadi Shabhaya, or the Shadharana from the Ashtanga Sangraha, or the Dashamula Kashaya, or the Churna, Gudika of any of these, and the Vadaka Bahara, Ashtavarga Kashaya. That these are the Ruksha Pajana measures that we commonly prescribe here. In case of Snigdha Pajana, we can go for the Gandharva Hastadi Kashaya or the Indugandham Kashayam, like that. And as a Rukshana measure, wherever it is intended, we can go for the Abhyantara Rukshana with Yavanna or Panchakola Kuladhadi Kashaya or Panchakola Churna, like that. In case of Bahya Rukshana, we can go with the Udvartana, Yavakola Kuladha or Bhrishta Tandula Churna for the Udvartana in Bahya aspect. And when we are moving on to Snehana and Svedana, we can select from a group like Vidaryadi Ganakvatha Khrida, which is different from the Vidaryadi Khrida. Vidaryadi Khrida is commonly known to everyone. If you see the Vadavyadi Chikilsa in the Apatanaga Chikilsa, in the Akshepaga Vyadi Chikilsa, there is a Khrida explained. Vidaryadi Ganakvatha Shira Rasai Shrutam. Okay, that is a special combination which is explained for the dystonic conditions. So that is available in the market. Rasakridam. It is commonly known as Rasakridam. It can be selected. Indugandham Kridam, which is very commonly used when there is Balakshaya, Gulgulidikta Grida, when the Samprapti is in Asthi Majja, we can go for the Gulgulidikta Grida in neurological disorders. Rasna Dashamula Grida, when there is the Parkinson's kind of condition, you can select the Rasna Dashamula Grida. Mahasneha can be used. And various kinds of Svedana procedures like the from the Parishega, the Drava Sveda or the Ushma Sveda. it can either be Ruksha or Snigdha according to the stages explained. We can go for the Dhanyamladhara or Churnavinda Sweda as the Ruksha measures, and the Snigdha Churnavinda Sweda and Kaya Sega as the Snigdha measures. For the Anulomana purpose, we can generally go for Snigdha Virejana. We use the Eranda Tailas like Sindhuvar Eranda or Nimbamridadi Eranda, Gantharvahasta Eranda. Sorry. And Mishraga Sneha is one valuable medicine that we use in Vadavyadhis also. In case of Vasti Yogas, for Anulomana purpose, we can go with the Yapana Vastis, any of the Ardhamatriga or the Prasarda Vastis also, we can select from them, the Kshira Vasti kind of procedures. And as for the feasibility, we can select Rasayana, either Gugulu, Lashuna, Bhallataka, Shilajadu. All these we have select Shilajadu, we have used in ataxia cases, Bhallataka in few cases of MND we have used, tried. Lashuna, many cases we have given. Gugulu, commonly used, or Ekamulika Prayogas for Shamana purpose, according to some disease Ashwagandha can be given, or accordingly some combinations can be selected, or yogas can be incorporated, or even Snehamante Balayacha. You can go for the Snehana itself. Some noteworthy Rasayana and Shamana yogas are summarized here. Atmagupta, Ashwagandha, Bala, Bhalladaga, the Mashatmagupta yoga from the Chakradatta, Ashtavargam from the Sahasra yoga, as Kshirapaga. All these are found beneficial in popular practice. Some Shamana Snehas like Naladadi Krida, Brahmi Krida, Bhalladaga Krida, all these are also used in the practice. And when we are using the Nasya Karma, when you are going for the Nasya Karma, Tailas like Karpa Sasthyadi, Shad Bindu are commonly used for Shodhana or Virejana kind of purpose with the Taila Nasya. And when we are going for the Brahmana kind of Nasya, Dhanandara Mavarti, Rasna Dashamula Kritam, Shuddha Bala Tailam are commonly used. And after the post Nasya, post Shiro Virejana, when we go for the Murda Daila procedures, either Shirovasti or Shirodhara is preferred with Karpa Sasthyadi Taila, Dhanantaran Taila, Mahamasha Taila, Shuddha Bala Taila. And at any stage of the disease, according to the condition, whether patient is undergoing Rukshana or Snehana, suitable talam is prescribed, especially in Anupadesha. See, this is very much relevant to Anupadesha like Kerala. Maybe it is not that much relevant in a Jangala Desha. But when the climate is humid, you have to expect this. So when we have a text called Arogya Raksha Kalpadruma, which some of you might have heard, it is a textbook famous for Kaumara Bhritya, but it has also several explanations of the Keraliya Kriyakrama. It says, Srodasu Kabharuddheshu Kuryat Murdhini Pichukriya. When there is a obstruction to the Srodas of the Urdhva Jatru with Kabha, then you have to do the Tala. So this can happen anywhere, anytime, isn't it? So according to that particular season, you can adopt Tala. In Kerala, almost all of the time we do the Tala. So reminding and summarizing our discussion, the need of Panchkarma in management of the neurological diseases, it is essential to remove the avaranatva of Kabha. We have to adopt some Panchakarma measure, either Bahyopachara or the Shodhana Karmas. It is also an essential tool to re-establish the Avyahada Gadi of Vata, that is any kind of Snehana, Brahmana is being pushed by Panchakarma will help in the restoration of the avyahada gati of vayu, which is vital in the cure of neurological disorders, and also to improve the efficacy of rasayana for making dhatu pushti. So if we are going for any rasayana or brahmana at the end, it has to be proceeded with some kind of shodhana measures which will clear the srotasas and then provide the strength to the particular srotas. And our focus areas that we have covered today, I just summarize that before ending my talk. We have discussed some of the pathologies, not all, I know, a very few only we have time to discuss. And depending upon that, we have considered the management and outcome perspectives along with the need for defining the limitations and boundaries and the some of the clinical experiences I have shared with you. And I would like to remind you to go back and read one particular chapter of Ashtanga Sangraha. So that chapter, Bheshajavacharaniyam, in the Sutrasthana, actually begins with this Samprapti Vikalpa. So regarding a Vata Vyadhi, how we have to do the framework of Samprapti, how we have to develop the habit of visualizing a Vikalpa Samprapti. It is being discussed there. See, Kimaharena Kupito Vayu. What kind of food items have caused the Vata Kova? Kim Viharena. What kind of activities have caused the Vata Kova? Rukshena Laghuna Shishirena Va Sahasena Vegarodhena Va Bhayena Shogena Va iti. So what kind of gunas, what kind of particular activities have contributed to the Vata Kova? That should be identified. Tatascha tat pratipaksham aushadham. Accordingly, the treatment should be designed. Prayujyamanam ashu siddhaye sampadyate. If that is adopted, that will be more beneficial, giving the optimum result to the patient. So we should do this framework of Chikilsa like Shamana, Dipana, Pachana, Rukshana, selection of medicines or Kriyakrama with a fixed duration and an expected outcome. Then further go into the Shodhana with respect to the Chikilsa Sutra. When we are considering the Shodhana Karma, if the seasonal considerations also need to be done, and accordingly the Purva Karma, Pradhana Karma, or Paschat Karma should be planned, especially whether the Karma should be Mridu or Madhya or Tikshna, that should be decided. And post the Shodhana, Anantara Karma Vichara, that is whether the Snehana is needed or Brahmana is should be needed, Rasayana, or the Shesha Dosha Pajana is needed, or repeated Shodhana is needed. All these should be considered. And along with that, rehabilitation and lifestyle modification should also be planned, helping the recovery of the patient. So with these few words, I would just give a take-home message. Treat the hypertension, treat diabetes, treat dyslipidemia in all cases of neurology that you get. Do not hesitate in treating them. Okay, that will in turn or may activate the neuroregenerative reserve in the patient, especially if the patient is having is in the early or medium stage of the disease. And go for the Nasya, Shirodhara, Snehapana for protecting the neuros. And always maintain the Koshtha Agni functions with Deepana, Pachana, Anulomana measures. And treat with patient-centric approach rather than the disease-centric approach. Do not just fall into the trap of mapping a particular treatment to a particular disease. Okay, and that particular treatment may not be suitable to a particular patient. To always focus on the patient. The patient should be the center of our approach and aim for realistic disease control measures. So with these few words, I thank each and everyone for the patient listening. I hope I have not taken extra time. Thank you, one and all.
Thank you, sir. Thank you, Vaidya Madhavan, sir. And it is very informative lecture and very useful for clinical practice. Most of the participants today are from clinical background and teaching background, so it will be useful for them. So now I invite all the participants to take part in the question answer session. You can unmute yourself and you can ask question. Sir, I have one question that there are in paralysis, there are two, according to modern, there are two, ischemic stroke and hemorrhagic stroke. So what, according to Ayurvedic Panchkarma, like what type of basti, what type of nasa we can use in both?
See, doctor, this is one aspect that I wanted to share from my experience. My limited understanding forces me not to map any kind of treatment or any kind of medicine to a particular pathology alone. So you cannot treat, you cannot say that Madhudailega Vasti works in ischemic stroke or the another kind of Vasti work in a stroke of infarct. Okay, it is dependent upon the patient. The patient having an ischemic stroke can be benefited with any type of Vasti. So first we have to understand that whether the patient requires Sandarpana or Abadarpana. So we know what kind of Vasti are Sandarpana, we know what kind of Vasti are Abadarpana. So what our duty is to identify the patient need. Okay, so generally we don't favor that approach in the management. That is our understanding. That is how I have learned Ayurveda. Okay, and apart from, there are not two sectors: infarct, ischemia, hemorrhagic, space occupying lesion. There can be many other possibilities behind the stroke also. So in all these, depending upon the patient only, we have to take the management consideration. We have a group of therapies which work in well in stroke management. So from that, which one to pick is depend upon the samprapti of that patient. That we have to do. That is our job.
Sir, in stroke, they say that we should not perform any Panchkarma in the initial 45 days. Is it true or we can go ahead, sir?
Not fully true, sir. See, if it is a hemorrhagic stroke, we have to be very much conscious. If it is a TIA, you have to be very much conscious, because then if we initiate, suppose if there is a hemorrhagic stroke, if we initiate any kind of Murdha Taila or Svedana or Nasya, there is a risk of precipitating that hemorrhage, which will lead into further neuronal death. And also if there is a TIA, which might be recurring maybe in a short period, okay, there is a risk. So we should be very cautious in certain type of stroke. Others we can go, no problem. In others, it is good you start the treatment early.
Thank you, sir. If any question you can ask, unmute yourself. Sir, there are some question in chat box also.
Sure, sure. Let us see. is Frederick's ataxia treatable? Difficult, very difficult to say that it can be cured. But we can focus on the improvement in the activities of daily living of the patient and also the comorbidities. But we cannot cure it completely. In autism, how can we treat? That is out of the, I think, context. Today we are having a specific session on neurological disorders. Autism is an entirely different area. Okay. Then, any other questions?
Thank you, sir.
Kedanji,
Now, yes, sir.
any
yes,
other
sir.
questions?
No problem, sir. We will share in the group also. The recording will be
Sure,
also
sure, sure.
available. And thank you very much, sir. Now I request Dr. Prakash Singh, sir, to summarize the session and for the vote of thanks.
Thank you, sir. I'm audible. Am I audible?
Yes, sir, you are audible.
Yes, sir. Yes.
Okay. Thank you so much, sir. Thank you, Vaidya Subin Madhyabadam, sir, for expert invitation speak. Thank you, sir, for your knowledgeable lecture and for accepting our invitation and being with us today and share your knowledge about Panchkarma and all neurological disorder. Thank you so much, sir. I'm also express my sincere thanks to Vaidya Adarsh C. Ravi, sir. Thank you, sir, for being with us. And I'm also thankful to my Visvarvit Parishad National Executive Committee, President Govind Sukla, sir. Thank you, sir, for Mahesh Vyas, sir, General Secretary for Visvarvit Parishad, and Professor Yogesh Chand Misra, sir, Organizing Secretary, Visvarvit Parishad. I'm also thankful. Anil Sukla, sir. Thank you, sir, being with us. And I'm also thankful to Visvarvit Parishad Panchkarma Sambhasa team, National Convener Professor R.K. Gupta sir, National Co-Convener Professor Santosh Chavan sir, Coordinator Dr. Chetan Gulani sir, Co-Coordinator Dr. Rasheen Chandrasekharan sir. I'm also thankful to all Central Zone Coordinator Dr. S.K. Tiwari sir from East Zone, and Dr. Raja Singla sir from North Zone, Dr. Doda Basaya sir from South Zone, and Dr. Uttam Sharma sir from UP Zone, and Dr. Vipin Tawar sir from West Zone. Thank you, sir. Thank you, and all participants. Thank you so much being with us, and thank you, Dr. Shubin Vaidya Madam sir, for your speech and your experience. Thank you so much.
Thank you. Namaste.
Hello. It's over
Thank you,
to sir.
sir. Thank you, sir.